So, welcome back to another session on esophageal diseases. In this, we'll discuss about the investigations and especially on the barium contrast studies. For esophagus, we have the barium swallow test. So, radiological, we have the different studies including barium contrast studies. CT, we can take an X-ray, but the problem is esophagus is located in the posterior mediastinum. Therefore, an AP view wouldn't it wouldn't be appropriate for the esophagus. And one condition where we could take an X-ray in AP and lateral direction is a radiopaque foreign body, and here you can see here because it's an radiopaque foreign body, we can see a round object in the coronal plane, and if it's in the coronal plane, it is said to be in the esophagus, and if it's suppose an anteroposterior direction, if it's something like this, then it is probably in the trachea, which we should remove immediately, right? So this barium contrast studies we'll discuss in detail in this, and we have CT, which is done for staging of tumors. With oral contrast also we can do for perforation. Now, in barium contrast studies, let's see the anatomy first. The upper esophagus we know from the previous session. In the lower esophagus, we can see here there's some part called the tubular esophagus, and we have the vestibule here. So the tubular esophagus is nothing but the whole tube of the esophagus. This is the upper part, and the rest is the tube. And we have a lower esophageal sphincter, which is the vestibule here. So that is what we are getting over here. Tubular esophagus and a vestibule. Now, let's see the diseases. So the first of the diseases is, we'll talk about rings, we'll talk about webs, we'll talk about diverticular. A note here, diverticular we have already discussed in the anatomy video. If you haven't watched it, kindly watch it and come here so that it would be easy for you. Now, coming to the rings. So basically we have three rings in esophagus: A, B and C. There's a reason why I've written C before B, so we'll see that. So A ring is because of the muscular contractions at the junction of tubular and the vestibular esophagus. I told you what is tubular, what is vestibular. In between them there is muscular contractions that is producing a A ring here. So is this muscular contraction a sustained thing? Definitely it's not, and therefore it's a transient muscular contraction. So you can see here there is a esophageal A ring here due to muscular contraction. Again, it varies during examination, may not even persist. So this is the A ring over here. You can see this is the tubular esophagus converting into a vestibular esophagus. Now, next we have something called as a C ring. The C ring is a rare anatomical finding. So it's basically associated with the diaphragmatic indentation. We have the crura on both sides of the esophagus. So that will produce some ring. That is what is called as a C ring. Now coming to the main thing, which is a B ring. So B ring is it's actually a ring formed by the mucosa itself. So inside the lumen we have a constriction. So if this is the thickness, and if so suppose this is the walls of the esophagus and this is the lumen of the esophagus, there is a mucosa which forms the ring. Now based on this diameter, how much is the luminal diameter, we have three things. That is, if it's less than 13 millimeter, the patient would be definitely symptomatic. If it's more than 20 millimeter, the patient would be rarely symptomatic, and if it's from 13 to 20 millimeter, it's plus or minus. It could be either symptomatic or asymptomatic. Now, the problem is, if the patient is symptomatic, that's what we call it as a Schatzki-Gary ring, or basically a Schatzki ring. If it's not symptomatic, we call it as a B ring. If it's symptomatic alone, we call it as a Schatzki-Gary ring. And an interesting thing is, this B ring once formed, it decreases the incidence of Barrett's esophagus because the acid won't reach to the esophagus that much. Okay, so this B ring, let's see it in the barium contrast studies. So see here, this is the barium contrast study of the lower esophageal region. This is the tubular esophagus, which is later converted into a vestibular esophagus. Is this a permanent ring? Definitely it's a permanent ring, because mucosa itself is involved, it's not just the muscles here. So this is again a Schatzki ring here, right? And if you can see here, it's actually, this is the diaphragm here, and it's actually associated with the diaphragmatic herniation, or a hiatal herniation, not a diaphragmatic herniation, it's an hiatal herniation, is an associated factor here also, right? Again you can see a hiatal herniation over here, again a hiatal hernia. The Schatzki ring is associated with an hiatal hernia. Now these are the three rings which we need to know in the esophagus. Now coming to webs here, okay? So rings we have done, now we'll come to webs. Now what is webs is, again they are constrictions. It could be congenital or acquired, and mostly it's seen in the upper part of the esophagus, that is hypopharynx and the proximal esophagus. Right. Any syndrome associated is Plummer-Vinson syndrome, where will be the iron deficiency anemia, esophageal webs, and dysphagia. And for you, this is the image of the esophageal web. You can see here, there is a web which can or may not cause an esophageal constriction. So this is the esophageal web. Okay. Now we have finished rings, we have finished webs. Now we'll come to diverticula. So diverticula, already we know the anatomy. We'll just see the radiological representation. Okay. Zenker's diverticulum. Yes. You can see this is the early swallowing. This is the late swallowing. We can see a pouch over here. This is the anterior. This is the posterior. So in the posterior esophageal wall, we have a diverticulum. Right. Now coming to Killian-Jamison's diverticulum, it's a lateral diverticulum. You can see here, this is the AP view here, this is the lateral view here. So in AP view we can see a diverticulum here. Now we have something called as EIPD, just esophageal intramural pseudo-diverticulosis. Now what is pseudo-diverticulosis? This means that it's actually not a true diverticulum. Then why it is actually formed is, it's because of a dilated and inflamed submucosal glands. So what, let's see the image here. What are we seeing here? I'll just draw here. We are seeing something like this, right? We'll see some bulges like here. This is multiple small flask shaped outpouchings are being seen here, right? This is what is known as a pseudo-diverticulosis. It's not a true diverticulum. It's because of dilated and inflamed submucosal glands. Okay. Now, again, a differential for a diverticulum is a tertiary peristalsis here. So, in esophagus, we have primary peristalsis, secondary peristalsis, and we have the tertiary peristalsis. Primary and secondary both are propulsive. Okay, propulsive means it will push the food from the hypopharynx towards the GJ junction, right, or esophagogastric junction. But the tertiary peristalsis is tertiary is actually non-propulsive, and therefore, if it's propulsive, how would it be? There would be a dilation in distal portion and constriction in the proximal portion. So this is constriction, this is dilation. Okay, this is the constriction and this is the dilation. This is how it should be. But if it's non-propulsive, then here would be a dilation, then there would be a constriction. Again a dilation, constriction, dilation, constriction. It would be something like a diverticulum. Again we are seeing here pouches here. So this might also be a differential for diverticula, but how will it differentiate from a diverticula is that this tertiary peristalsis would come and it would also go. So it's not a persistent phenomenon, it's a very transient phenomenon. So this is where we will get confused, and after some time if you redo the test, you will get something like this. Okay, so there's no diverticula here, just a differential. Okay, so we have finished. What have we finished? Second thing was webs, first thing was a ring, and finally diverticula also we have finished. Okay, now let's see other things in the barium studies. Okay, so next we will come to herniation. So herniation, again hiatus hernia, we have three types here. First is the sliding type, where the esophageal gastric junction itself comes above the diaphragm. So something like this is what you will get. Okay, so this is the diaphragm over here. So this is the sliding type. Rolling is the fundus along, fundus itself will go here. So something like this. Okay, this is what is called as the rolling type. Still the thing is below the diaphragm, but the fundus is along above the diaphragm. Okay, this junction is at its place, but the fundus goes above. So this is the rolling type. And mixed is, we have both things here. Let's see in the image here. The sliding you can see here. Yeah, so you can see here this. This is where the junction should be. It has moved up here. So this sliding type. Now this is also the same sliding hydatania. Now coming to rolling is, we can see a fundus air shadow over here. So this is the rolling type of fill. And mixed I have not pasted any image here. Again, mixed you will get both of these characters. Now coming to other conditions where we can see some characteristics thing is the infective and inflammatory pathology. So these things I am not touched very deeply into. I'll just mention which diseases you will get the changes, and if you're interested, I will give the link in the description so that you can learn more about these. Okay, so this video we are not going to cover about these things. Okay, so infective, you have TB, CMV, Candida. Inflammatory, we have Crohn's, Behçet's, and eosinophilic esophagitis. All these will have changes. Again, in barium enema, you'll get them. What is what, and yeah, right. Now coming to some named signs. So we'll end this with this session. Like, we all know the name signs, right? So we have started from anatomy. We discussed few pathologies, and now we are ending with name signs. So first thing in CA esophagus, what will you get is apple coat deformity, rat tail appearance, which is characteristic here, or shouldering effect. I'll tell you why it is. Right, so this rat tail, so it's something like a rat over here. Okay, some rat, and again it is having a tail over here. Okay, so this is what is a rat tail appearance. Shouldering is, you're having something like this. Okay, shoulders are being formed here. So this is the shouldering effect, and it's also known as an apple coat deformity. These all are seen in CA esophagus. Now esophageal leiomyoma, what will you get is so simple. So this is the wall of the esophagus. You are having a leiomyoma over here. So how will the barium enema, barium swallow appear? It would be something like this, right? So this is what is known as a punched out appearance. So you can classically see here. So there's some punched out appearance. Hey, this is esophageal leiomyoma. Now next we have the achalasia cardia, where we will get a bird beak appearance. Yes, you can see here. So this is the bird beak appearance over here. So some bird's beak here. You can see its eye. So something is going like this. Okay, imagine like that. Okay, so this is the bird's beak appearance in achalasia cardia. So these are the name signs. I'll just ask you a question, which if you know, you can answer in the comment section, right? So what is the typical lesion seen in CME esophageal diseases? So that is the question. Kindly comment in the comment section. Thank you so much.